Welcome back to the deep dive. Usually, when we talk about medicine, we have the luxury of time. We talk about chronic conditions, long-term recoveries, or, the slow progression of disease.
Right. We can think, we can plan.
But today, we are stripping all of that away. We are walking through the double doors of the emergency department, past the waiting room, and straight into the trauma bay.
It's a completely different world in there. The pacing, the noise, the stakes, it all shifts.
And specifically, we're looking at a scenario that keeps even seasoned trauma surgeons up at night. We aren't talking about a broken finger or a concussion.
No.
We are talking about vascular trauma. This is the moment a major pipe in the human body, an artery or a vein, is compromised.
Compromise is a polite way of putting it.
Mm.
In the medical literature, vascular trauma is consistently described as one of the most rapidly fatal injuries a human being can sustain.
A race against the clock.
It is the definition of a race against the clock.
That's what struck me most when I was reading through the case studies and protocols for this dive. I always assumed that in a major car crash or a shooting, it was the organ damage that got you.
Yeah, that's a common thought.
The ruptured spleen, a lacerated liver. But the data says otherwise.
It's a common misconception. Organ damage is bad, certainly, but organs generally sit there. If you nick a liver, it oozes.
Right.
If you sever the femoral artery, you are looking at a high-pressure system pumping the body's entire blood volume onto the floor in a matter of minutes.
It's a difference between a leaky faucet and a fire hydrant.
Exactly. The primary killer in vascular trauma is uncontrolled hemorrhage. You bleed out.
And even if you survive that.
Well, even if you survive that initial catastrophic loss of blood, you immediately face the second enemy, ischemia.
Which is the starvation of the tissue.
Right. If the pipe is cut or blocked, everything downstream, your hand, your foot, your entire leg, stops getting oxygen.
So the surgeon is fighting a war on two fronts simultaneously.
Yes. You have to stop the patient from dying of shock, but you also have to race to get blood flow back to the limb before it rots and, requires amputation.
There is a statistic I highlighted in bold red on my notes, and I think this sets the stage for everything we are going to discuss today.
I think I know the one you mean.
It's said that hemorrhage is the most common preventable cause of death in vascular trauma.
That is the sentence that haunts every trauma team.
Preventable. That is a heavy word.
It is.
It implies that the injury itself didn't have to be fatal. It implies that the difference between a survivor and a statistic comes down to the speed and accuracy of the doctor's decisions in the first few minutes.
It puts the responsibility squarely on the clinical algorithm.
Mm?
You cannot hesitate. You cannot misread the signs.
I do.
If you follow the wrong path in the decision tree, or if you wait for a test you didn't need, the patient dies from an injury that was technically survivable.
So, that is our mission today. We are going to decode that algorithm. We want to understand how trauma surgeons look at a mangled leg or a gunshot wound and decide in split seconds whether to rush to the operating room or send the patient for a scan.
We need to unpack the decision matrix because, contrary to what you see on TV, it isn't just gut instinct. It is a highly rigorous, logical framework designed to eliminate doubt when chaos is breaking out all around you.
Okay, let's start with the basics. The nature of the beast. When we say vascular trauma, we are talking about damage to the vessels. But the way that damage happens seems to matter just as much as where it happens.
Hugely, yeah. Mechanism is everything. We generally divide these injuries into two massive categories: penetrating trauma and blunt trauma.
Penetrating seems most intuitive. This is the knife wound, the gunshot, the shard of glass.
Right. This is usually a clean injury, relatively speaking.
Yeah.
Something sharp enters the body and lacerates the vessel. It might punch a hole in the side of the artery, or it might transect it.
Cut it completely in half.
Cut it completely in half, exactly.
And from a diagnostic perspective, I imagine this is somewhat obvious. If a guy comes in with a knife sticking out of his thigh, you have a pretty good geographical clue where the problem is.
Precisely. You see the hole in the skin, you know your anatomy, the femoral artery runs right into that hole. Connect the dots.
But then you have blunt trauma.
Ah, yes. The dark cousin of penetrating trauma.
That's a good way to put it.
Blunt trauma is much more insidious. This is the motorcyclist who gets T-boned, the construction worker with a crush injury. The skin might not even be broken.
No visible wound.
The leg might look swollen, sure, but there's no fountain of blood spurting across the room.
So you might look at that and think, okay, he's banged up, maybe a broken bone, but the plumbing is fine.
And that is how you lose a limb. Because inside, something catastrophic has happened. to the architecture of the artery.
Explain that to us. If nothing cut the artery, why does it stop working?
So think of an artery not just as a rubber tube, but as a complex pipe with layers. The innermost lining is called the intima, and it's incredibly delicate, like a layer of cellophane or wet tissue paper. It has to be perfectly smooth so blood can slide by without clotting.
Okay, I'm visualizing the cellophane lining.
In a violent blunt impact, like a car bumper hitting a knee, the artery gets stretched. It gets yanked hard like a rubber band. The tough outer wall might hold, but that delicate inner cellophane layer, it snaps.
An intimal tear.
Exactly. And when it snaps, it doesn't just lay flat. The force of the blood flow peels it up like a flap of wallpaper coming loose in a hurricane.
Yep.
That flap creates a trap door inside the artery.
So the pipe clogs itself.
It triggers the body's clotting cascade. Platelets see that torn, raw edge and think, emergency, patch this hole.
Yeah.
They swarm the area, forming a massive clot, a thrombosis that seals off the pipe completely.
Wow.
So on the outside, the leg looks bruised, maybe. Inside, the blood flow has hit a brick wall.
That is terrifying. It's a silent, invisible amputation happening in real time.
Which is why the physical exam is so critical. You can't rely on seeing blood on the floor. You have to hunt for the silence.
Before we get to the hunt, let's talk about the first few seconds the patient rolls through the door. There is a universal language in trauma called ATLS, Advanced Trauma Life Support.
The ABCs.
Airway, breathing, circulation. It's the mantra.
It keeps you disciplined. It keeps you from getting distracted by, a gruesome leg injury when the real problem is that the patient can't breathe.
So A is airway.
Step A, airway. If the patient can't breathe, it doesn't matter if their leg is falling off. They will be dead in 3 minutes from hypoxia. So you secure the tube.
B is breathing.
Step B, breathing. Are the lungs inflating? Are they working?
And C is circulation.
And C is where our topic lives.
Right.
Circulation involves two things. Is the heart pumping? And is the blood staying inside the body? This is where we control hemorrhage.
Now, this seems straightforward. Stop the bleeding. But I want to push back on something I read in the protocols. There's this rigid rule that says, do not delay hemorrhage control for imaging.
It's the golden rule. It's written in blood.
But let's play devil's advocate. We are in 2026. We have incredibly fast CT scanners. We have technology that can build a 3D model of a bullet wound in seconds. If I'm a surgeon, wouldn't I want that roadmap?
It's a tempting thought.
Wouldn't I want to know exactly what I'm walking into before I slice the patient open? Why is going to the scanner considered such a mistake?
That is the classic trap of modern medicine. We're addicted to data. We love the donut of truth, the CT scanner.
Right.
But here's the reality of trauma. The scanner is a lonely place.
A lonely place. What do you mean?
When you take a patient to the CT scanner, you are usually moving them away from the trauma bay. You are moving them down a hall or up an elevator. You have fewer nurses, fewer lights, less equipment.
Isolated.
And most importantly, you cannot operate inside a CT scanner.
So if they crash?
If they are hemodynamically unstable, meaning their blood pressure is tanking because they were bleeding out, and you put them in that machine, they will die in that machine. We call it the tunnel of death for unstable patients.
Wow. Okay, so the logic is, better to open them up blind and put your finger on the bleeding hole than to have a perfect picture of a corpse.
100%. Time is blood. If they are unstable, you bypass the scanner. You go straight to the operating room. You open, you clamp, you save the life. The roadmap is a luxury for the stable patient.
That distinction, stable versus unstable, seems to be the first fork in the road.
It is the absolute first question you must answer.
But let's assume we have a patient who isn't actively dying right this second. They are stable enough to be examined. This brings us to the core of the episode, the decision matrix.
This is the hard signs versus soft signs framework.
I love this concept because it feels like a checklist for a pilot. It removes the guesswork.
It has to. In that environment, you need rules.
Let's talk about the hard signs first. These are the red lights.
These are the absolute non-negotiable indications for immediate surgery. If you find one of these signs, the debate is over. You don't scan, you don't wait, you cut.
Let's run through them, but I want to get visceral here. I want to know what these actually look and feel like. The first one is active pulsatile bleeding.
Okay, this is the horror movie scenario. It's not an ooze. It's not a trickle.
It's a pump.
It's a jet. It is pumping in rhythm with the heart.
Rough.
Spurt, spurt, spurt. It means the arterial wall is breached to the outside world.
Okay, hard to miss that one. The next one is expanding or pulsatile hematoma.
A hematoma is basically a blood clot under the skin, a big bruise. But a pulsatile hematoma is alive.
Alive.
You put your hand on this swelling mass on the patient's thigh, and you can feel it kicking against your palm. Thump, 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 thump.
It's beating.
It's beating because the artery underneath is pumping blood directly into that cavity, and the pressure is building.
And an expanding one.
If you take a marker and draw a circle around the bruise, and 2 minutes later the bruise has crossed the line, that's an expanding hematoma. It's a ticking bomb. The vessel is still bleeding under the skin.
Okay, next heart sign. Absent distal pulses.
This one's simple but critical. You grab the wrist or the top of the foot, you are looking for that rhythmic tap of life. If it's gone, the road is closed. No blood is getting through.
Now, this next one is my favorite term, clinically speaking. A brute or a thrill?
Ah, yes. They're two sides of the same coin. They both describe turbulent flow.
What do you mean by that?
Normally, blood flow is laminar smooth, silent, like a deep river. But if the artery is crushed or has that intimal tear we talk about, the flow gets chaotic, it swirls, it's violent.
Like rapids in a river.
Exactly. If you put your stethoscope over that spot, you hear a whoosh sound with every heartbeat. That's a bruit, French for noise.
And a thrill.
But if it's really bad, you don't even need the stethoscope. You put your fingers on the skin and it feels like. Have you ever petted a cat while it's purring?
Sure, that vibration.
That buzzing vibration under the skin? That is a thrill. If you feel a purring cat on a human being's leg, that is a shattered artery. Heart sign. Surgery now.
And the final heart sign is palpable signs of acute limb ischemia. This is the dying limb.
This is the combination of signs we call the 6PS. Pain, pallor. It's white as a sheet poikilothermia, which means it's cold to the touch.
So, pain, pallor, cold.
Then paresthesia, pins and needles. Paralysis, they can't move their toes. And finally, pulselessness, which we already mentioned. If the leg is cold, white, numb, and they can't move it, the tissue is screaming for oxygen.
So to recap the protocol, if I find any of these, a purring cat, a cold foot, a spurting wound, I skip the CT scanner.
You skip everything. You are wheeling them to the OR while you are calling the surgeon, because every minute that passes is muscle dying that you can never get back.
But medical cases are rarely that black and white. What about the soft signs, the yellow lights?
This is where it gets tricky. This is where the real clinical judgment comes in. These are patients where your gut says something is wrong, but the evidence isn't screaming at you.
Give me an example. History of significant hemorrhage.
It's okay. Let's say the paramedics bring in a guy and say he bled like a stuck pig at the scene, huge pool of blood. But now you look at the wound and it's dry.
Not a drop.
Get stopped. Arteries can spasm. They have muscle in their walls. When cut, they can clamp themselves shut temporarily, or a clot formed. But that clot is fragile. That spasm can release.
So it's a ticking time bomb.
Right. Just because he isn't bleeding now doesn't mean the artery is safe. It's a soft sign. It warrants a closer look.
What about diminished pulses?
This is subtle. It takes experience. You feel the left wrist, and the pulse is booming. You feel the right wrist, the injured side, and it's there, but it's weak. It's thready, faint.
So blood is getting through, but not enough.
Or it's getting through a side channel. We call them collaterals. It means the main highway might be blocked, but some traffic is getting through on the back roads. But it's not enough. It's a huge warning sign.
So for these soft signs, nerve injury, small, non-expanding hematomas, weak pulses, we don't rush the surgery.
No. This is where you can take a breath. This is where the CT scanner becomes your best friend. We have time to be precise.
Let's talk about that investigation phase. Section 4 in our outline highlights the technology. If we have a soft sign, what are we ordering?
We are ordering a CTA-computed tomographic angiography.
How is that different from a normal CT scan?
It's all about timing and contrast dye. We inject a special dye into the patient's veins. We time the scanner perfectly so that the picture is taken at the exact moment the dye is rushing through the arteries. It lights up the entire vascular tree.
So on the screen, you see bright white rivers of blood.
And you see exactly where the river stops, or where it leaks, or where it narrows to a tiny trickle. He gives the surgeon a perfect roadmap. Okay, the blockage is 2 centimeters below the knee joint. That changes the incision. That changes the approach.
It's the gold standard.
It is the absolute gold standard in vascular trauma evaluation for a stable patient.
What about Doppler ultrasound? We use that for blood clots in the legs all the time. Seems like it would be useful.
It can be, but in a trauma way, it's difficult.
Yeah.
It's messy. There's gel everywhere. The patient is in pain. There might be open wounds.
And it's operator dependent.
Very operator dependent. If I'm bad at ultrasound, I might miss it. A CT scan is objective. It slices the body into millimeters. You can't hide from a CT. It's the definitive answer.
Okay, let's move the timeline forward. We've done our survey. Maybe we found a hard sign, or maybe the CT scan confirmed a tear. We are scrubbing in. We are going to the operating room.
This is where the rubber meets the road.
The outline describes a hierarchy of needs in the OR, and it's brutal in its simplicity. Priority 1, control hemorrhage.
Stop the dying. That is always rule number 1. You cannot fix a pipe if the house is burning down around you.
Priority 2, restore circulation.
Save the tissue.
But then there is this doctrine, life over limb. It sounds like a movie catchphrase, but in the OR, I imagine that is a devastating decision to make.
It is the hardest decision a surgeon makes. It's gut-wrenching.
Walk us through that moment.
Imagine you are working on a young patient, maybe 20 years old. His leg is shredded from a motorcycle accident. You want to save it. You know if you amputate, his life changes forever. But his blood pressure is dropping. His pH is 7.1. He's full of acid. He's cold. His blood isn't clotting anymore because he's lost so much, and he's in shock.
He's spiraling.
He is in what we call the triad of death: hypothermia, acidosis, coagulopathy. If you spend another 2 hours trying to sew those tiny mangled arteries together to save the leg, he will die on the table.
So you have to make the call.
You have to make the call.
Yeah.
You look at the anesthesiologist, they look at you, and you both know. You amputate the leg to stop the metabolic drain, you close the stump quickly, and you get him to the ICU. You sacrifice the limb to save the life.
That is heavy. But let's say the patient is stable enough for a repair. What are the tools in the toolbox? What can you actually do to fix the pipe?
If the cut is clean, if the two ends are healthy, we do an end-to-end anastomosis. We trim the ragged edges back to healthy tissue and sew the two ends of the pipe back together with incredibly fine stitches.
Like splicing a wire.
Exactly. But if a chunk of artery is missing, maybe a bullet took out 2 inches of vessel, we can't stretch it.
So you need to bridge the gap.
We do a graft. We usually take a vein from the patient's other leg, the saphenous vein. We reverse it because the veins have valves that would block the flow, and sew it in as a bridge, a new piece of pipe.
But there is a third option mentioned in the research that I found fascinating, the temporary vascular shunt. This sounds like a MacGyver move.
It is the ultimate MacGyver move. It is a life-saving, limb-saving trick. It's for that patient we just talked about, the one who is dying, who can't handle a 2-hour complex graft surgery.
So what do? You
take a sterile plastic tube, just a simple tube. You shove one end into the top of the artery, the other end into the bottom of the artery, and you tie them in place with vessel loops.
It's a jumper cable.
It is literally a jumper cable for an artery. Blood flows through the plastic tube, the leg gets oxygen, the bleeding stops.
That's fast.
It takes 5 minutes. You leave the wound open, cover it with a sterile dressing, and rush the patient to the ICU to get warm, get blood products, and stabilize.
Then you come back later to finish the job?
You come back 24, 48 hours later, when he's alive and stable, to do the real definitive surgery. It's called damage control surgery.
That is incredible. It buys you the one thing you don't have, time.
It's all about buying time. Don't fix it perfectly, fix it enough to survive the night.
Now, I want to pivot to the detective work. Section 6. Special scenarios. These are specific injuries that, according to the source material, are traps. They fool you.
These are the ones that get missed, and they have terrible consequences.
Let's talk about the knee dislocation. Why is this specific injury so notorious for vascular damage?
It comes down to anatomy. The popliteal artery runs right behind the knee. In most parts of the body, arteries have some wiggle room. They're surrounded by fat, they can slide around.
But not there.
But behind the knee, the popliteal artery is tethered. It's anchored by muscles and fascia. It's like a guitar string pulled tight across the back of the joint.
So if the knee joint dislocates, if the tibia and femur separate,
the artery has nowhere to go. It is stretched to its breaking point and it snaps, or the intima tears. The rate of vascular injury with a knee dislocation is incredibly high, something like 30 to 40%.
But here is the trap. You mentioned earlier that sometimes the knee pops back in.
Right, and that's the danger. A football player gets hit, the knee blows out, but then he hits the ground and it pops back into place. Or the paramedics reduce it on the field to relieve pain.
So he gets to the ER and his leg is straight.
Exactly. By the time he gets to you in the ER, the knee looks swollen, sure, but it's straight. The bones are aligned. You x-ray it and the bones look fine.
So you might think you're in the clear.
You might think, good news, no fracture, and send him home with some crutches. But that artery was stretched to the breaking point 10 minutes ago. It has that intimal tear. It's clotting off as we speak.
And he loses his leg.
He loses his leg by morning.
So the rule is, If there is any suspicion of a knee dislocation, you assume the artery is hit until proven otherwise.
You assume it, you check the pulses meticulously, you get an ABI and ankle brachial index to compare blood pressures, and honestly, you have a very, very low threshold for getting a CT angio. You do not trust a normal-looking knee after a dislocation.
Now, there's another trap listed here regarding fractures, and this one seems so important. Pulse presence does not exclude vascular injury.
This is the one we hammer into medical students over and over again.
It seems counterintuitive. I mean, if I feel a pulse, doesn't that mean the pipe is open?
It means some blood is getting through. But remember those collateral vessels we talked about?
The side roads.
The back roads. The body has this amazing redundant network of tiny vessels that bypass major arteries. If the main highway is blocked by a fracture or a clot, traffic might take the side streets.
So you can feel a pulse from that?
You might feel a weak pulse at the ankle because of these side streets, but it's not enough blood to keep the muscle alive for long. It's just a trickle. It's enough to fool you, but not enough to save the limb.
So a pulse can give you a false sense of security.
A deadly false sense of security. The phrase is, it has a pulse, he's fine. No. If the mechanism was violent and the pulse is even slightly different from the other leg, you investigate. Never trust a pulse blindly in trauma.
Let's move to the aftermath. We've saved the life, maybe we've even repaired the vessel, but the danger isn't over. Section 7 covers complications. The big one is compartment syndrome.
This is probably the most common and devastating complication after a vascular repair.
Explain the physics of this. What is a compartment?
Okay. Your muscles, in your calf, for example, are grouped into tight bundles. These bundles, these compartments, are wrapped in a layer of tissue called fascia.
Okay.
And fascia is a tough, fibrous tissue. It's like leather. It does not stretch at all.
So the muscles are in a fixed leather casing.
Exactly. Now, imagine that leg was ischemic. It didn't get blood for 4 hours. Now we fixed the artery and blood is rushing back in. The muscle swells up. It gets edematous.
Like a sponge soaking up water.
A sponge, right? The muscle wants to expand. But the leather casing, the fascia won't let it. So the pressure inside the compartment starts to skyrocket. It gets tighter and tighter and tighter.
And eventually the pressure is higher than the blood pressure.
I got it. The pressure gets so high it collapses the capillaries and veins. It chokes off its own blood supply from the inside. You can have a perfectly repaired artery, great flow coming down the leg, but the muscle is strangling itself to death inside that fascial sac.
And the fix for this is drastic.
It's the only fix.
Yeah.
A fasciotomy. You take a scalpel and you slice the leg open from knee to ankle. You cut through the skin and that leather fascia to release the pressure.
You slit the casing of the sausage?
It's a brutal but accurate analogy. Ideally, the muscle bulges out, turns pink and happy because it can finally breathe again. It's a gruesome wound to manage later, but it saves the leg.
There's one more complication that feels almost ironic. Reperfusion injury.
Ah, yes.
This is the idea that letting blood back into the limb can actually make the patient sicker. How does that work?
It's a cruel physiological joke. When the leg is starving, when it's ischemic, the cells are dying, they're breaking down. In that process, they release a flood of toxic byproducts.
What kind of toxins?
Potassium, lactic acid, myoglobin from the muscle cells, all these things are just sitting in the leg.
But they're stuck there because there is no blood flow.
Right. They're quarantined, they're trapped. But the moment you, the hero surgeon, fix the artery, release the clamp, and restore blood flow,
You flush it all into the body.
you flush all those toxins back into the main circulation. And it's a tidal wave.
And that goes straight to the heart.
The potassium can stop the heart instantly. The myoglobin can clog the kidneys and cause renal failure. So paradoxically, the moment of success restoring flow is one of the most dangerous moments for the patient's overall physiology. Anesthesiologists have to be ready to combat that chemical wave with drugs.
It really highlights that vascular trauma isn't just plumbing, it's a systemic biological event.
It affects every organ system. It's a total body insult.
We have covered a massive amount of ground today, from the intimal tear to the shunt to the fasciotomy. I want to bring this home. The source material provided a rapid-fire recap, but I want to do this as a mental walkthrough. I'll throw the scenario, you give me the rule.
Let's do it.
Scenario 1. A patient arrives, gunshot wound to the leg, blood is spurting across the room.
Hard sign, direct pressure, tourniquet if you need it, straight to the OR. No CT scan, do not pass go.
Scenario 2. Car crash victim. Leg looks swollen but no external blood. Pulse is weak but present.
Soft sign. The weak pulse is a trap. Do not send this patient home. Order a CT angiogram immediately.
Scenario 3. The patient is in the OR. The leg is shredded, but the patient is cold, blood pressure is 60/40, and they're oozing from every IV site.
Damage control. Life over limb. Insert a temporary shunt, pack the wound, get out of the OR, resuscitate them in the ICU, and come back tomorrow.
Scenario 4. You fix the artery, patient is stable, but 2 hours later the calf is hard as a rock and he's screaming in pain that's out of proportion to the injury.
Compartment syndrome. The pain is the key. Do not wait for a pulse to disappear. It's too late by then. Perform a fasciotomy now.
That framework is incredibly clarifying.
It has to be. In the heat of the moment, you don't rise to the occasion. You fall back on your training and your algorithms.
As we wrap up, I want to leave the listener with one final thought regarding the psychology of this field. You mentioned earlier that hesitation is the enemy.
It is. The hardest thing for a young doctor to learn is to bypass the comfort of the scanner. We are trained to be thorough, to gather all the data, to have the perfect picture.
But in vascular trauma, being thorough can be fatal.
You have to be decisive. You have to be comfortable with a degree of uncertainty.
It's about trusting what you see and feel with your own hands.
If you feel a thrill, you know the artery is broken. You don't need $1 million machine to tell you what your hand just told you. It's a lesson that applies to a lot of high-stakes environments. When the hard signs are there, you act. You don't paralyze yourself with analysis.
Time is tissue. A simple rule, but one that governs everything in this deep dive.
Absolutely. Time is tissue, time is muscle, and ultimately, time is life.
Thank you so much for breaking this down. It's a side of medicine we rarely see, but it's fascinating to see the logic behind the chaos.
My pleasure. It's great to talk it through.
And to our listeners, thanks for diving deep with us. Hopefully you never have to worry about hard signs or soft signs, but now you know. If you do, there is a plan. We'll see you on the next one.